See, Drew always keeps us honest. Amar.
Hey guys, my name is Amar. I'm currently an intern here at UAB. I'm originally from Michigan, but went to undergrad and med school in Kansas City, so go Chiefs. And I'm ready to present this case for you guys if you guys are ready.
Okay, and Rachel, why don't you introduce yourself because you're our expert.
Yeah. Hey, I'm Dr. Rachel Lee. I'm in the Division of Infectious Diseases at UAB. I'm a UAB lifer almost. I didn't go to college here, but I've been here for all of my medical career. I'm also at the VA, and then I do healthcare epidemiology at UAB.
Okay, Amar, go ahead and start the story.
Yeah, so just for context, I have a 63-year-old guy for you. He has a past medical history of end-stage renal disease. He started dialysis about a year ago. He does still make urine, and he straight casts 4 times a day. He has a history of HFrEF. His ejection fraction is 25 to 30%. Cirrhosis secondary to hepatitis C, which has been treated. Hypertension, COPD, hyperlipidemia, type 2 diabetes, which is diet controlled, BPH, history of polysubstance abuse. He previously used cocaine and cocaine and heroin. He claims that on admission he no longer uses that, and history of tobacco use. And he presented to the ED with complaints of dyspnea on exertion, orthopnea, and abdominal swelling. When we talked to him, we had found out that he had missed multiple dialysis sessions as he had difficulty with transportation. On exam, he was volume up with bilateral crackles, unauscultation of his lungs. He had JVD noted to the angle of his jaw, and he also had +2 pinning edema of his lower extremities. And then on admission, his labs were remarkable. He had a CBC with a white blood cell count of 5.2, hemoglobin of 12.5, platelets of 248, and then his BMP on admission showed a sodium of 136, potassium of 5.1, chloride of 95, bicarb of 21. He had a BUN of 80, creatinine of 12.5, and a glucose of 117.
Slow down because Sean can't go but so fast. We never really did figure out exactly what his end-stage renal disease was from. Because this is a patient that Amar and I took care of together. And he had very good reason for, he had a very, I don't want to get into it because I want to give him some anonymity, but he had a very good reason for not being able to get to his dialysis in terms of transportation, and had missed about three dialysis sessions. He comes in, and this is real simple. What's the first thing you want to do, Natasha?
The first thing, I want to dialyze him.
Right, and that's what we did. And that's what we did. There was no secret here. His cirrhosis is totally compensated, and so that's how he comes in, and then something happens 3 days later, and the problem we had is we couldn't discharge him because he was too far away from his dialysis chair, and he couldn't get back and forth. And so he ended up being in the hospital a lot longer because we were trying to find him a new chair. And in between, they remodeled his dialysis unit. And it was a social work mess. He's a wonderful, wonderful guy. And everybody really, really liked this patient. So he was always easy to work with. So Amar, tell him what happens next.
Yeah, so on hospital day 4, during the night, the overnight team gets a page. He spiked to fever. Initially, his temperature was 100.8, and then he's on recheck in a different site, his temperature was 102. And then when the overnight team went to go see him, he was just shivering. He looked toxic, but his vital signs were stable besides his fever.
Drew.
Oh boy. So I guess given the fact that he's been accessed for his dialysis, he's got ESRD, which is an immunocompromising condition. He has cirrhosis, which is an immunocompromising condition. He has COPD, which could predispose him to lung infections. I'd want to do I'd want to get a full sort of infectious workup on this guy. I'd want to get blood cultures on him. I'd want to get a chest X-ray to see if we can, to see if he has a pneumonia of some sort. The fact that he is still making urine and straight cathing. At that, if he's doing clean intermittent caths, it's a little bit less of a risk of infection, but I'd still probably want to get a urine culture. But otherwise, if he's just having rigors and fever and not right now, I'm basically looking for a localizing symptom to try and narrow what my infectious workup is going to be, because right now it's going to be a lot of poking and prodding for this guy, and I want to see if I can limit the amount of that I'm doing to him.
So Anne-Marie put in a very one of my favorite quotes. This guy had Rigors, and so the likelihood ratio for bacteremia is close to 5. Rachel, why don't you tell them from an infectious disease specialist viewpoint, and you attend on the wards also. What do you expect the night float people to do when they see a patient with Rigors?
Well, I can tell you what I did as a resident that was not the right thing. So, when you get called with a fever and you just say, get blood cultures, urine cultures, and a chest x-ray without going and examining a patient, that's where you get into trouble. And so my hospital epidemiology side kind of kicks into gear now when we have patients with Foley catheters or when we have them with central lines. Not every fever needs that kind of workup. But as everybody is saying, with Rigors, that's a very different thing, right? If someone's actually rigoring in the bed, you really do want to get blood cultures as close to that moment as you possibly can. And then, assessing him for any other symptoms that he may be having during that time. I will say, when patients have bacteremia, they can also have back pain. So, they seem to be correlated together. So you just have to think about that as you're potentially treating a patient for bacteremia.
So, Rachel, is there a temperature that in and of itself, without Rigors, gets you to work? And how do you decide whether or not you're going to go down the sepsis road or not?
Yeah, that's a great question. If you ask the internist, the trigger is 100.4. If you ask the trauma surgeon, it's 101.5. So everybody has their own different cutoff. I look more at what's the trend, especially if this patient has been here for 3 days and then all of a sudden they have a new fever. That to me is significant. And especially now that we're in COVID times, 3 days in, they may be, at the beginning of COVID and may be infectious from that standpoint.
So, Natasha, they went ahead and got blood cultures and urine cultures. I think they got a chest. Did we get a chest X-ray more?
We did, but it was unremarkable. It was negative for any acute infectious process.
So do you want to put the patient on antibiotics? Oh, you get the urine out. We'll give you the urinalysis results because they come back pretty quick.
Yeah.
Okay.
So his urinalysis, and he notes specifically talking to him that his urine has started to appear dark and cloudy, which is new. So we did get a urinalysis and we did a full septic workup like Drew had mentioned. His urinalysis specifically, it had +2 protein, +2 blood, +3 leukocyte esterase, but the nitrites were negative. And he had 77 RBCs and more than 182 white blood cells.
Okay,
Yeah,
Natasha.
So definitely, even without the UA, I would have probably, like Dr. Lee said, definitely go examine the patient, try to see what's going on. If you saw the bag of cloudy urine, that would be a trigger. And then just in someone who's so profoundly immunocompromised, it's harder for them to spike a fever. And then I know in ESRD patients, a trend that I kind of noticed, I don't know if this is official, like seen in literature, but abdominal distress, like things like nausea, vomiting, diarrhea, I noticed a lot on the renal service. So I would ask him if he's having any of those symptoms. He has a ton of sources. I'm not sure what his what his access is for dialysis, but that's definitely a source. If he has ascites, then SBP could be a source. Endocarditis is always a possibility as well. It seems like urine might be playing a role here, but I wouldn't anchor to that. There could be multiple processes going on. In the era of COVID, like this is exactly the person that would get COVID in the hospital with all the comorbidities.
So he has an excellent AV fistula with a great thrill, and I think Amar examined that, and there wasn't any redness or anything. It wasn't like he had plastic in his system.
Exactly.
I will say, Bob, there have been studies that have looked at least in the setting of a Foley catheter, what about cloudy urine and sediment and foul smelling urine? And what is the relationship to having, correlating to a true infection? And the data is abysmal. You would be surprised how it does not correlate at all to having a UTI. And in fact, the CDC says that odorous, cloudy, or discolored urine in the absence of any other symptoms does not mean that you should get a urine culture.
But it was appropriate in this case because he just had a Rigor.
Right. So he has other signs and symptoms, right? He's complaining of, the foul smelling urine in addition to a fever, which is new. That's where those other symptoms are important. But how often do I hear like going around and the nurses saying, "Oh, this urine looks very cloudy," and it's just, it's really hard to break that view.
Okay, Natasha, what antibiotics do you want to use? Do you want to put him on antibiotics?
Yes. So he is pretty high risk for MRSA. So I would vancomycin for sure. He is on dialysis. So usually Sepsis is something, just an easy one to dose with dialysis. With a normal chest x-ray, I don't know that he needs like anaerobic coverage right now. I would probably start there. And then
okay.
I had one more question. Has his AV fistula been manipulated in any way recently?
Amar?
I mean, it was used for dialysis, but during this episode, when they went to examine him specifically, he has a left upper extremity fistula, and it had a good thrill. There was no warmth, tenderness, or swelling around the site, and he denied any pain at his dialysis site as well. Also, as far as other sources for infection, they did a bedside ultrasound overnight. He didn't show any signs of ascites, so there was nothing to tap. And then on physical exam, his heart had a regular rate and rhythm. They didn't appreciate a new murmur.
Okay. Amar, what did they actually start him on?
So overnight, they started him on Vanc and Sepsis.
Rachel, could you comment on antibiotic choice in a patient like this?
Yeah, I think I don't disagree with starting broad in a patient that has sepsis. And so I think the key here, this patient does have sepsis, unknown etiology currently, especially if you're in the middle of the night taking care of this patient. I think the good thing is that he has not had any sort of antibiotics on admission. And I think prior to this, he's never had any sort of antibiotic resistant infections. So that helps me, if you can clue into where the sepsis is coming from. So on admission, if you're in the emergency department and if someone is complaining of cough and shortness of breath and fevers, and they have a localized pneumonia apart from COVID, let's just say COVID doesn't exist. I wish we could say that. Then you would want to really aim ceftriaxone and azithromycin. You really want to get those community-acquired pneumonia medications. Now, this person has been in the hospital for 3 days, so he is at risk for hospital-acquired infections. And I think ceftazidime is a good choice in this patient, in addition to vancomycin, until you get more information.
Any questions before we go on to the next phase of this man's problems?
I guess my question would be, why ceftaz and not cefepime? Because I guess there's everyone in the chat is basically saying that it's either not available or ceftaz is restricted for basically just for people who have Pseudomonas. Oh no, Farron wants to use as Trianan.
I would say the
Okay.
two medications
Sorry.
are equivalent. Ceftazidime and cefepime. What are you trying to cover here? You are trying to cover Pseudomonas. That is what you are concerned about, right? Ceftriaxone has great gram-negative coverage, but it is missing things like AMP-C beta-lactamase resistant organisms. So those are going to be things like Enterobacter, Klebsiella. Those are the ones that you would be concerned that they could have resistance. So if you're in the hospital, so ceftazidime and cefepime both work fairly equivalently, although I will say that cefepime probably gets more of those AMP-C beta-lactamase producing organisms. The issue, the reason that we are all at UAB saying ceftaz is because it's really hard to break a nephrologist of ceftaz. They love ceftaz, and it's just because of the ease of dosing with dialysis.
Okay. Amar, what happens next?
Yeah, so kind of going back to what happens next. I will say also we had morning labs at this time. So they did show, his CBC did show a new leukocytosis. So his white blood cell on admission was 5. And then on morning labs, and it had stayed around 5. And then on morning labs today, his white blood cell was 14. I don't have a differential with that though. And then his blood cultures actually ended up coming back that same night. And I can tell you guys that his blood cultures ended up growing 4 out of 4 gram-negative rods.
Oh, goody.
And so, Drew, what do you want to do now?
So GNRs. I mean, at this point, we could. I'm thinking we'd probably want to back off on the vanc. If we, considering that we don't have, we had a concern for MRSA before, but now that it's just growing for just GNRs, vanc is not going to be useful for anything. So the other thing that I would be concerned about is what's the source of the GNRs. Are we dealing with a are we dealing with urosepsis, or are we dealing with some or are we dealing with some other source? I'd also probably want to have those GNR speciate out just to see if we can narrow the coverage, further.
They'll get speciated out, but it's going to take us another 24 hours before we know what we're dealing with.
True
but we
that.
will know. And he's scheduled for dialysis later today, let's say. So you're making rounds in the morning. You know he's growing gram negatives. Do you give him another dose of vancomycin? Do you just leave him on the ceftaz? Do you switch antibiotics?
I'd probably leave him on the ceftaz, and stop the vanc. The vanc's not doing much of anything. What we're trying to cover with the vanc is not there. So, in the interest of antibiotic stewardship, I'd stop the vanc, and also maybe give his whatever is left of his kidney function a break.
Okay. You agree, Rachel?
Music to my ears. Although you can't really blame someone if it's just within 24 hours to immediately stop. I mean, what if it's a polymicrobial infection and we don't? I mean, this patient does have sepsis, so it's no one's going to ding you for doing an additional day's worth of antibiotics. But at the same time, I agree that everything is pointing to a gram-negative infection, and I think that's fair to take it off.
Okay, so Amar, we get some identification the next day?
We do. And his urine culture also grows the same thing. Both grow Klebsiella.
Ooh.
Natasha, now what do you want to do?
Interesting. I'm trying to think. I have not seen many Klebsiella infections other than in like people's past multi-drug resistant. So I'm not sure what our biogram is at UAB, but it's not one of the space organisms. I'm honestly not very familiar with Klebsiella. I would probably honestly go on Up to Date and see if Septas usually covers it. If we're being honest, that's what I would do.
Rachel.
And then why is he growing it in his urine? Probably because he's straight cathing himself, I guess.
That is certainly what the team surmised. Rachel, if we'd called you in at that point, and we don't call you in just yet, if we called you in at that point, what would you have taught us about antibiotics for Klebsiella and further workup?
Right. So, Natasha brought in the AMP-C beta lactamases. And so the MySpace organisms are the ones that I think about. If you remember MySpace, I guess that's old school, or Space M, whichever one you want to do. So that's Serratia, Pseudomonas, Acinetobacter, Citrobacter, Enterobacter, and then Morganella. And then there are a couple of others. But I think the key here is understanding what AMP-C is. So it's a cephalosporinase. And they can either be inducible or non-inducible. And so what that means is inducible means where in the presence of an antibiotic, what you do is you kill off all the happy bacteria and then they will induce that resistance. And so then you'll see someone that initially gets better and then they get worse. With Klebsiella, they do have AMP-C beta lactamases. But those are non-inducible typically. So what that means is if you're looking at your resistance profile when you get it, and it says that it's susceptible to ceftriax, and you can believe that. Whereas something like Enterobacter, which has a lot of inducible resistance, when you look at it and it says, oh, it's susceptible to ceftriaxone, but it's got a whole bunch of other resistant cephalosporins, that's when we ID doctors say, whoa, wait a second, maybe we need to rethink this and go to something like cefepime. So all that to say is ceftazidime probably is a good antibiotic for Klebsiella, especially if he's getting better, which hopefully, within 24 hours, someone should be responding to antibiotics pretty well.
Let's help Sean here. And let's make sure we get all the organisms here. Pseudomonas was in there, I believe.
Yeah, it's Providencia and Pseudomonas, I think, it's like double P.
And was there an A?
Yes, Acinetobacter.
This is, having this in case I ever have to deal with this, at least by seeing it, it's helping me. I hope it's helping other people. So would you have just waited to see what the sensitivities were, keep the patient on Ceftaz for now, and then reassess after we get sensitivities back?
Yes, that's what I would do. It's always helpful if you know where your hospital's handy dandy antibiogram is. Right. Where at the VA, it's in the antimicrobial stewardship kind of tab. At UAB, it's kind of hidden a little bit, but I think those things are incredibly helpful to know what's typically resistant at the hospital.
So Amar, we get the resistance back. What do we get?
So we get the resistance back. I don't have it written down here, but the big thing, it was resistant to Septaz, which we ended up continuing in this patient because he was a dialysis patient, and we just dosed it with his dialysis sessions.
It was resistant or sensitive?
It was sensitive to Septaz.
That's sensitive to Septaz. Okay.
I was say, wait a second, I don't remember this.
Okay, so Amar missed this part because we gave him Thanksgiving Day off. So the resident and I made rounds without him that day. But why don't you tell him we got you up to speed on what happened. So why don't you tell them the story of what happened on Thanksgiving Eve?
Yeah. And so I'll give a little bit of background too. This was hospital day 4. This all transpired. And then he improved significantly after starting antibiotics. He continued to stay on our service, just waiting to find a new dialysis chair. Over the next few days, he had occasional episodes of nausea and chills, and he also complained of some left-sided back pain, but it was pretty vague. And every time you talked to him, he said, "I just want to get out of the hospital. I'm just laying in this bed all day." On hospital day 7, he did intermittently spike a fever of 100.4, but at that time, we had morning labs available. He didn't spike a new leukocytosis, and his fever downtrended by itself, so we continued to monitor. But then on hospital day 10, he specifically in the morning complained of left lower back pain, and he was shivering again in bed.
Okay, he had another true Riger. This actually did happen on when we came in that morning. Night Float reported it to us, and then he gave us the story and told him that he had this left flank pain. So Natasha, what do you want to do now? What are you thinking?
Yeah, so I guess there are two buckets you can think of. Either we didn't get source control initially, we gave antibiotics, but we were not able to achieve source control, or there's a new infection. I think in him it could be either. I think it's more likely that maybe we just didn't get source control, especially with left flank pain. I'm worried about pyelo. That would be where my head goes to first, especially if we have data showing that, Sepsis should have been treating the Klebsiella. So with pyelo, I'm trying to remember, I think it's a CT scan usually with contrast, but also an ESRD patient who's still making urine, I know you still don't want to use contrast because that can still hit their kidneys and worsen their urine output. But I guess I would be concerned enough. I'd probably touch base on nephrology.
So
Can
pyelo
you do an
usually gets better with
ultrasound for
antibiotics.
pyelo? Sorry?
Pyelo usually gets better with antibiotics. Is that right, Rachel?
Yeah, it should.
Okay, so what else could be causing
I mean,
this?
an abscess.
Okay, abscess. And you can name a bunch of abscesses, but what would be the ones most likely?
Like a renal or something in the urinary tract would be the most likely.
Yeah, perinephric abscess or something like that. Anything else that you can think of?
Again, I would always just go back anytime you're accessing the fistula. That's always going to be a source. So I would still be worried about that. I assume the night team, when he spiked fever, probably got blood cultures again. I don't know. So that could be useful information. If he's not having a cough, I mean, pneumonia is usually there's some kind of clinical symptoms.
So at this point, the resident and I examined the patient, and I said, I think we probably ought to check with infectious disease now. So I knew Rachel was on, and I had her number in my phone because we work on stuff together. And so I called her up and told her the story. And Rachel, why don't you tell them your thought process and the conversation you had with me at that time?
When I think about bacteremia, I like to think about the source. I mean, that's why we're all ID doctors. We're like little sleuths trying to figure out where it came from. When you have a patient with MRSA bacteremia, we're like, well, maybe you need to do a lumbar imaging or things like that. And so when I think about Klebsiella, where is it most likely going to be? In a patient that doesn't have symptoms of pneumonia, the biggest ones are going to be the urinary tract and then something in intra-abdominal. And given that he had symptoms of, left flank pain and those sorts of things, and then also when you look at his urinalysis, he has 3+ blood. I love urinalyses because you can get so much information from them, including if the urine pH was high, then you would think, oh, could this be Proteus? And, then you think about stone formation. So we had talked about, should we be concerned about the fistula? And because gram negatives and you had a pan-sensitive organism that should be responding to the bacteria, to the antibiotics you have them on, that always makes us think, okay, there's some other source. And then, we go down that route of finding that source. Drug fevers and things like that are kind of diagnosis of exclusion because we don't really want to miss a really bad raging infection that needs to be taken care of.
Would a drug fever sometimes cause Rigers?
It shouldn't typically, and it would be more cyclical, what I would think, rather than these rigors that he's complaining of.
Yeah. And I guess you could get back pain with that, but this was specific flank pain.
Yes, it was not anywhere near the spine. You know, when I examined him, he, you know, when he points to the right where it hurts, you know, it's very helpful. It's a pointing sign.
Yes. And he's a very intelligent patient. I mean, he could really describe what's going on very nicely. So we decided we did need to get imaging. So it turns out that the radiologist on call was one of my former students. So I called him up and I asked him the question. And so here's the question for you to ponder, Drew. We all agreed we needed a CT scan. And the question is, do we need it with or without contrast?
Oh boy. Of course, there is the constant refrain that Dr. Joel Topf that's ringing in my mind, that contrast-induced nephropathy is very, very rare, especially if you are instilling the contrast in a vein. And we have a question that would be helpful that we would want to know, that contrast would help us answer, which is, do we have an abscess, which can be elucidated by contrast? And this guy is on dialysis, so the contrast can be taken out. So my answer to the question would be yes, use contrast.
Okay, Natasha, what do you think?
I would too. I've been in a situation before where the ED got a CT without contrast, and we were trying to decide if the patient had pyelo, and ultimately the radiologist, I called him, this was on night float, and talked to him, and he was like, honestly, I can't tell, there's some stranding. I think it would make a diagnosis a lot easier. I know that everyone has different thoughts on contrast-induced nephropathy. I'm not sure where I stand yet, but I would probably pull the trigger as well.
So Rachel had suggested another possible cause other than, we really didn't think it was pyelo because we knew he had him on good antibiotics. We were really concerned about an abscess, but she clued us into something else. And then I called up the radiologist. And what was that, Rachel?
Remember, what did I say? I mean, I was really concerned about stone formation in him.
So you said that it could be a kidney stone. I said, dialysis patients get kidney stones?
Yeah, and I said yes. And then after we got off the phone, then I texted my dad, can dialysis patients get kidney stones?
Her dad is one of the nephrologists of the VA, a longtime colleague. So I call up radiology and said, we'd like to get a CT this morning. And fortunately, the radiologists work from home, but they can look at the film immediately. And he said, everything that you're looking for, I can tell without contrast. There's no reason to do contrast because we were looking for a stone and we're looking for an abscess, and he could tell either one of those without doing contrast. So in the absence of needing contrast, we got one without contrast. And by the way, that's the radiologist that we're starting to plan some future episodes where he's going to go over films with us as how to look at a chest X-ray, how to look at a chest CT, how to look at abdominal films, abdominal CTs. If y'all think that's a good idea. I think everybody thinks.
Uncle Bob, why hasn't this been done earlier?
Well, we have to redo the schedule because 7 to 8 Central Time is dinner time for him. So we're going to have a few episodes that start at an hour earlier. Mm-hmm. And it's just I have to find someone to collect the right X-rays and stuff like that to make it most interesting. So Amar, tell them the story.
Yeah, so we ended up reflexing. We got the CT abdomen and pelvis without contrast. And specifically, it showed mild left-sided hydronephrosis, and a stone was seen in the left uteropelvic junction measuring 0.7 by 0.8 centimeters. There was also stranding in the retroperitoneum, concerning for inflammatory changes around the kidneys.
Wait. He a wait, a stone? How?
So okay, so that's sort of when Rachel first mentioned it to me, I said, kidney stone? Okay, but he is still making urine. And then I talked to some nephrologists, and the rate of kidney stones doesn't really change after you're on dialysis. That to me was a revelation. It wasn't real large. That we called urology. I mean, why don't you tell them the rest of the story, Usman, because Amar got him confused with his brother, who's a resident.
No worries. So we did end up consulting urology, and they recommended surgery. So they put in a left ureteral stent. And then during the surgery, they actually noted that when they were putting in the stent, there was purulent urine efflux from the left ureter.
And it all got better, and it all got better.
Yeah,
Rachel,
so
why don't you give us some teaching points about this case that'll help all of us do a better job in working this up. The question that I asked myself, I know that I anchored on self-cath. How often does self-cath cause a Klebsiella, and should we have looked for something earlier? I'm trying to beat myself up because I'm an internist, or was it okay that we waited to see that he didn't get better on his own?
I mean, I think it's fair what we did. If you think about it, he had been on dialysis for a year, but was self-cathing during that time, and so he had not had an infection, from what I recall, at all during that time. So these symptoms were very new for him. It's not like one of those patients that self-caths or has neurogenic bladder and they know the drill when they get an infection. This was very new. So I think it's fair to see if someone will defervesce and improve, and he also slightly improved initially, and then it got worse. And so I wonder if that stone may have kind of gotten into that UP junction, and then when he developed hydronephrosis, that's when he really developed those rigors again because of that purulent efflux that he saw. So potentially he was trying to resolve it on his own, and then unfortunately his UP said no way.
Yeah. So I sort of just overlooked the red cells in his urine. I think I might have made a mistake in retrospect. I mean, and the retrospectoscope is our best scope. And we see a lot of urinary tract infections, and we see more urinary tract infections in women, and a lot of urinary tract infections, the red cells also. Should that have swayed us at all or not? Does that sway you at all?
Yeah, I mean, you can see 3+ blood with a urinary tract infection. I think with him, given that he had not had that before, and the negative nitrates, I know that someone had mentioned, like, wait, how could this be a UTI if it has negative nitrates? Well, there can be false negatives as well. So potentially you could have repeated a urinalysis first to see if the blood had resolved or if some of the white blood cells had improved, and maybe that would have clued you in a little bit sooner. But I don't think that anything was necessarily done wrong with what happened, and he got surgery, which is what he truly needed. I think if he had been discharged early, that would have been the bad thing to do.
The good news is the VA is totally open the Friday after Thanksgiving, and so the ORs are open. That's not considered a holiday in any way, as opposed to Christmas week, that the whole week is a holiday. But it was that was our case. So Natasha, what did you learn? You and Drew both did a great job. So what did you learn that you want to take home from this discussion?
So I think I should have probably thought of a kidney stone sooner, but kind of just like everyone else, I was not aware that dialysis patients actually have the same incidence. So that's a big learning point. And then I also, for some reason, thought you needed contrast to see an abscess on CT. So I learn more and more about radiology every day. But what else? The space organisms is always a good review. I had not heard of Morganella, so that one was new for me. But when I did ID consults, we talked about those organisms a good bit. But yeah, this was really helpful.
Drew.
Yeah, pretty much the same things that Natasha had mentioned. And I guess it's sort of good to be back into the mindset of trying to figure out, you know, the ultimate goal of ID being what is the source of the infection and how do we make sure that we get everything.
Amar, we took care of this guy together, and I already told you what I got out of this. What were the biggest things you learned from taking care of this man?
Yeah, I think Drew and Natasha pretty much covered everything. I will say that I researched this on my own too, just because I was also interested that, a patient with end-stage renal disease presenting with a kidney stone. And actually, like Dr. Center already mentioned, the incidence is similar if they have end-stage renal disease or don't. But the other thing that I thought was interesting, which I have here, was there is a diagnostic dilemma for patients with end-stage renal disease. Specifically, we got our CT scan without contrast, and in patients without end-stage renal disease, they usually form calcium oxalate stones. But in patients with end-stage renal disease, they tend to develop mineralized matrix stones with a lower calcium content. So that can be part of the diagnostic dilemma because those stones can be radiolucent. So we were lucky in our case that we were able to clearly visualize the stone on CT, but it's something else to consider if you still have a high suspicion for a kidney stone in an end-stage renal disease patient.
Well, Rachel, you've been a huge help to all of us. What are the big things you want us to have learned from this case? 'Cause I think it was a very, this is not a totally weird case, but it's a very instructive case.
Yeah, I think for me, it's very easy to have premature closure if you've got urine culture and blood cultures that are growing the same thing. Like we ID doctors like to put it all together. But continuing to come back to your patient and saying, all right, why aren't they getting better? Because we know antibiotics should work fairly quickly in bacterial infections. And if they're not working, then think through what else could it be and why aren't they getting better?
Great. Sean, you get the last word.
Actually, Amar, you taught me. I have not thought about radiolucent stones since I think third year of med school. And so remembering that those are actually an entity, and if you have a picture that kind of fits with that, to keep digging for that stone. So thanks, Amar.
Yeah, I guess the radiologist's reasoning was even if he couldn't see the stone, he'd see some hydronephrosis. So you could deduce that there was a stone there if you found some hydronephrosis. Hope everybody learned a lot, and happy Inauguration Day tomorrow.
Mm-hmm.